Girish, can we start?
Yes, sir. We are ready. We are ready. Shall we start, sir?
Yeah, please announce.
Good afternoon, everyone. Participants will be starting the session now. Once again, a warm good afternoon, everyone, all the participants. Thank you so much for joining. A hearty welcome to all of you to today's part of the webinar series conducted by Pooja Bhagwat Memorial Mahajana Education Center, PG Wing of SBRR Mahajana First Grade College, Mysuru. Without much ado, I request our beloved director, sir, Dr. C.K. Urticaria, Director of PBMMEC, to give the opening remarks. Sir, over to you, sir.
Thank you, Tejasvi. Very good afternoon to one and all. It's indeed a matter of great pleasure to have this most important webinar this afternoon, hosted by Life Sciences Department of Mahajana Postgraduate Center under the stewardship of the renowned scientist, Dr. S.R. Ramesh, who is also the chief scientist of life sciences in our PG center. So this, in my view, this is a very, very important webinar because allergy and its therapy happens to be the most important aspect of health in today's world. And as a common person, I understand that allergies occur when our immune system reacts to a foreign substance such as pollen or maybe bee venom or pet dander or a food that does cause a reaction in most people. So it's also a matter of satisfaction that allergy shots, also known as SEIT, or the most commonly used and most effective form of allergy immune therapy. And it's also nice to hear from the world of medicine that it's not very expensive in India. So a lot of research is going on in this area. And we have one of the greatest experts in this area, Dr. Nagendra Komrala, who is the founder, director of Bangalore Allergy Center, Bangalore. I very heartily welcome Dr. Nagendra to this important webinar. It's our great pleasure to have him this afternoon. He would be introduced formally. I take this opportunity to thank him on behalf of Mahajana Education Society and also on behalf of Mahajana Postgraduate Center for making himself available to us in spite of his very busy schedule. I look forward for a very productive webinar and it will go on record in our PG Center, particularly on the records of life sciences. Thank you so much. I wish every success for this seminar. Thank you.
Thank you so much, sir. Thank you so much for the kind words. Now I request Dr. Ramesh Essa, CEO and Academic Advisor, SBR Mahajana First Grade College, Chief Scientist, Life Sciences, PBMMEC, Mysuru, to talk about a few words about the webinar.
Very good afternoon to everyone. I'm here on behalf of the Life Science Department of our PG Center and also on behalf of Mahajana Education Society. And probably most of you were with us when we organized a last webinar, which was once again hosted by Life Science Department a month ago. Actually, during that webinar, the first webinar, we also got two doctors who were into teaching and research. So that is one category of doctors which I wanted to always bring them to expose to our students. They were very good teachers and also researchers, especially in the research on molecular virology. Now, today we have with us another expert who is a doctor and also who is into research. For the last 4 decades, that is for over 40 years, he has been practicing and also he is also doing research in the field of allergy, a very narrow field, but a lot of work he has done, and he has developed various technologies to treat or to alleviate the problem of allergy. So you will get to know during the course of webinar the things he covers, etc. Actually, the term allergy has become a very common term in our life. It's not only confined to medicine field, but also in our life, it has walked on in many corners to express dissatisfaction or unpleasure things that occur around us. We always say, I am allergic to so and so, I am allergic to that guy, I am allergic to this food, etc., etc. So actually, allergy now it is common in our society, but technically speaking, allergy is synonymously used for one kind of reaction in immune system that is known as hypersensitivity. Well, if I go to briefly about hypersensitive reactions are of 4 different kinds. They are type 1, type 2, type 3, and type 4 hypersensitive reactions. Well, Dr. Nagendra Prasad, who is allergist and immunologist, he will not be focusing on all the 4 types of hypersensitive reactions, but he will focus his attention only on type 1 hypersensitive reactions, by taking some examples of allergy related to pollen, allergy related to food stuff, etc., or medicine or whatever you can think of. And he will also focus on the strategies that are developed towards alleviation of this hypersensitive type 1 reactions. So with this brief introduction of what's going to happen in this webinar, I would request my colleague, Dr. Grace Chandra, to formally introduce Dr. Nagendra Prasad, while thanking him profusely for being with us this afternoon, for sparing his precious time to our students. Thank you so much.
Thank you, sir. Again, I thank the speaker of today's presentation, Dr. Nagendra sir, for accepting our invitation. Now I take the privilege and honor of introducing Dr. Nagendra to all the participants. He is a full-time practitioner of allergy and applied immunology at Bangalore, at his own Bangalore Allergy Center since 1980. He has obtained his degree from prestigious Mysore Medical College. He has 27 original papers presented and published at the journals and conventions of national and international repute. He is an active member of European Academy of Allergology and Clinical Immunology since 2000. He is an overseas member of the American Academy of Allergy, Asthma and Immunology since 2002. He is a prestigious fellow of Indian College of Allergy and Immunology in 1984. He is a life member of 17 medical societies in India. He is the chairman of South Chapter of Indian College of Allergy, Asthma and Applied Immunology. He is a member of major national committees. One of them is National Expert Committee, DCG, for formulating regulation and batch release of diagnostics and therapeutic allergens in India since 2015. He initiated SLIT drops in India since 2003. And SLIT tablets in the year 2014, approved dispensing license from Karnataka Drug Coordinator. He has a patent approved of invention of a nasal filter mask, and SLIT stripe. He also has a joint patent, peak flow indicator. His patent is pending with SLIT HDM tablet since 2015. We hope it gets approved shortly. Currently, sir is working full-time as a practitioner at Bangalore Allergy Center, Bangalore, under Allopathic Clinics Accreditation Program. And it's been granted with 3 years with effect from 2020, valid until 2023. With this very short introduction, I request you, sir, to take over and also present the ever-exciting topic of allergy and immunotherapy. Over to you, sir.
Thank you. Shall I open the PowerPoint now? Is it visible? Okay. Yeah. Is it visible? I should minimize my screen, right? Visible now? Perfect, fine. Shall I start? Yeah. Good afternoon to everyone. At the onset, I thank Dr. Ramesh, who initiated and motivated me to present this day for allergy and immunotherapy. And also I thank Dr. Rhinitis, and also I thank Dr. Girish in coordinating this session. And welcome to all participants. Today I'll be talking about the allergy and immunotherapy. You may be already knowing about basics of immunology, but still I am covering a few points on how related this immunology to allergy. This is my center, which is situated on 4th block, Jayanagar, established in 1980. Topics today we are addressing to definitions, roles of the immune system and immune system like organs, cells, molecules, and types of immunity, innate and adaptive, hypersensitivity, allergy classification, management of allergy disorders, and allergen-specific immunotherapy. What is the immune system? It is an organ and a process of the body that provide resistance to infections and toxins. What is immunity? It is a biology. Immunity is a balanced state of multicellular organisms having adequate biological defenses to fight infection, disease, or other unwanted biological invasion while having adequate tolerance to avoid allergy and autoimmune diseases. The immune response is the body's response caused by its immune system being activated by antigens. The immune response can include immunity to pathogenic microorganisms and its products, as well as autoimmunity to self-antigens, allergies, and graft rejections. Now, what is the role of the immune system? It is a defense against microbes. It's a defense against the growth of the tumor cells, kills the growth of tumor cells, tolerance to environment, homeostasis, and destruction of abnormal or dead cells, like dead red or white blood cells or antigen antibody complex. Now, the immune system has got a team, which is having an organ and the cells and the molecules. We will look into each. The organs are tonsils and adenoids, which is very well everybody familiar, and it should be preserved for the lifelong. If anybody advises to keep away from the tonsils, please refuse them, and it is an essential unit which has to be in the lifetime. And the thymus, lymph nodes, spleen, Peyer's patches, appendix, lymphatic vessels, and a bone marrow. Now, what are the cells? The cells like lymphocytes, T lymphocytes, B lymphocytes, and also plasma cells, nature killer lymphocytes, monocytes, macrophage, granulocytes, neutrophils, eosinophils, and basophils. What are the molecules? Molecules are like antibodies, complements, cytokines, interleukins, and interferon. I think all the people who are familiar about this. Now, coming out of the immune system, we have two types. That is adaptive immunity and innate immunity. And adaptive immunity is a natural and artificial. Natural will be a passive especially a maternal and active, which is exposed to the infections. Artificially is a passive antibody transfer and an active immunization. So now you have to understand how the immune system starts from when the baby is in the womb, which is a variant of Th2. It produces only Th2. As it bonds, and this Th2 gradually shift into the Th1 variation because of serial infections. And in certain cases, this Th2 will always be maintained, and it is shifting to Th1 will be a little reduced, retarded, because of the a very few serial infections and because of the total protection to the baby and a hygiene and a small family size. So more protection to the baby is not warranted because we had to give a baby to expose to the certain environments so that Th2 will be reorganized to Th1. Now, types of immunity. As I told you, there's an innate, is a non-adaptive. There is first line of immune responses, which is always the mother gives to the total protection to the baby. That is an innate immunity and relies on the mechanisms that exist before infection. Number two is an acquired, that is an adaptive. Second line of response, if innate fails, relies on mechanisms that adapt after infection, handled by T and B cell lymphocytes and genetic determinant. Now, innate immunity is based on genetic makeup, relies on already formed components, rapid response within minutes of infection, is not specific, and some molecules, cells respond to a range of pathogens, has no memory, same response after repeated exposure does not lead to a clonal expansion. So these are all mechanical barriers or by surface secretion like skin, pH in the stomach, and a cilia in the, especially in the, and humoral mechanisms like lysozymes, basic proteins, complement, and interferons. Cellular defense mechanisms is natural killer cells, neutrophils, macrophages, mast cells, basophils, and eosinophils, which you are all familiar. Now, coming on to the adaptive immunity is the second line of response. Based upon the resistance acquired during a life, relies on genetic events and cellular growth, responds more slowly over few days, and is specific. Each cell responds to a single epitope on an antigen. Has anamnestic memory, repeated exposure leads to faster, stronger response, leads to clonal expansion. Now, the natural process, active immunity is a clinical and subclinical infections will be there. And artificially we give them the vaccination like live and a killed allergen specific immunotherapy, aeroallergens. These are all how we artificially give to the human being. And passive immunity naturally is via breast milk or the mother is transmitting to the placenta, through the placenta to the baby when it is in the utero. Artificially, we give them immune serums, immune cells, omalizumabs or anti-AG or biologicals, which is coming into the forefront in a recent time. These antibodies or immunoglobulins belongs to the gamma globulin fraction of serum proteins. This is a protein having a light chain and a heavy chain, and a brown which is marked, which is a variable region, and the constant region is a heavy chain. And all immunoglobulins are need not be antibodies. And commonly we have a 5 kind of antibodies like IgG, IgM, IgA, IgD, and IgE. In 1966, Dr. Ishigaka from Japan, and he is the main person who discovered this IgE molecule. After discovering of IgE molecule, we had a shift in the paradigm of understanding of allergy disorders. So later, Johnson at the same time, Bennick Hedge from the USA, he also claimed that he has found a similar molecule, and they shared their Nobel Prize. IgE is a mediated type of type 1 hypersensitivity. It's a monomeric. Major functions applications are associated with anaphylaxis, role in immunity to helminthic parasites and allergy disorders. See, it is also applied in serodiagnosis, infections and non-infectious allergies, example bronchopulmonary aspergillosis, parasitic disease, specific IgE in allergy disorders. Hypersensitivity reactions cause a cell damage through excessive immune response to antigens. And this is one common word we use called hypersensitivity, which is an overreaction to infectious agents. Allergy, we call it as overreaction to environmental substances. Autoimmunity is overreaction to the self tissues. Primary, we have secondary immune response. Primary response is a short-lasting, smaller in magnitude. Secondary on the second exposure, longer in duration, larger in magnitude, develop memory cells following primary response. Failure of immune response can result in hypersensitivity and immunodeficiency. This is a flow chart, just a small cartoon. I wanted to make you to understand how the allergens enters into the system. Commonly in allergies, we have, I will be speaking about these allergens in a later time. And these antigens, which enters into the system and which is always scavenged by the dendritic cells. Dendritic cells, like a constables, they will be always moving here and there. The moment they feel the odd person is there, and he'll be caught. Similarly, dendritic cells will be capturing these antigens, and it leads into the genetic gene activation, and either it is stimulating the Th2 cells, which secretes IL-5, interleukin-5 and interleukin-4, and leading on to the eosinophils production by inflammatory cells and Th2 memory cells. If it is stimulating the B cell, then in turn plasma cells, they produce more of IgE. If it's in a normal person, they stimulate more of Th1 cell and interferon gamma. They produce more of killer T cells. They secrete more of IgG molecules. And also stimulate the B cell, plasma cell, they produce more of Th1 memory cells. This is a small pathway to make you to understand how the immune system works. In a hypersensitivity type 1, whenever the exposure to these allergens on the primary and the secondary, and these allergens comes near to the mast cells. Mast cells is already prefixed with the IgE molecules. When the two IgE molecules binding on one allergen, which mast cells activates and release the granules, and this is called degranulation. And this degranulation will be having a vasoactive amine symptoms that I'll be discussing shortly. Just to make you to understand how this allergy inflammation starts, how the cellular communication starts. You see, is a subject, is a small cartoon, is a model. Just he is inhaling one of the molecule. Example, you can take it as a pollen. The pollen is inhaled, and this pollen is absorbed through the mucous membrane in the nasal cavity and enters into systemic circulation. And there it is captured by the antigen presenting cells, which is found in the systemic circulation. And once it is captured, it releases certain cytokines. And these cytokines will stimulate the B cell. And this B cell releases some cytokines and the produce more of plasma cells. And these plasma cells producing the IgE molecules into the circulation. These IgE molecules will bind on the mast cells which is already having a receptors. IgE receptors are there in the mast cell which binds, And after binding, when the allergens comes in contact between the two, bridging between the two molecules of the prefixed immunoglobulins, then it activates and the regulation of the deregulations and releasing the vasoactive amines. What are those mediators are released either from the mast or basophils like histamine, tryptase, and proteoglycans, including a heparin and a chondroitin sulfate, and a platelet activating factor, leukotrienes, prostaglandin, bradykinin, cytokines, and IL-1 and tumor necrosis factor, and IL-2, IL-3, IL-4, IL-5, and IL-6. Now, as Dr. Ramesh said, there are 4 types of sensitivity, which is happening, which is classified by Gell and Coombe classification, which is also holds good. And earlier we had 4 types, and we have subtypes also. And type 1, we call it as immediate, and type 2 is called cytotoxic, type 3 is called immune complex mediated, and type 4 is a delayed or cell mediated. This is the picture where I want to show you how the type 1, type 2, type 3, and type 4. Type 4 is having subtypes 4A, 4B, 4C, and 4D. We are more interested in the type 1, which is mediated by the IgE and which is involved with the mast cells. Another one is called the type 4B, which is also mediated through eosinophils and which is also inducing the type 1 allergies. And type 4A is more concerned with the skin disorders like sensitized lymphocytes, which is producing the contact dermatitis. So this is the one which is 4 types under the type 4. So the type 4C is inducing more of contact dermatitis, and type 4B is more of the responsible induction through eosinophils and inducing the respiratory symptoms. Now, coming on to the allergy. An allergy is referred to as exaggerated reaction by the immune system in response to exposure to certain foreign substances, which is commonly harmless in non-allergic individuals. In allergic individuals, the body recognizes a foreign substance and the allergic part of the immune system generates a response through IgE antibody. Allergy producing substances are called allergens, and an example like aeroallergens like pollens, dust mites, molds, animal proteins or animal danders, foods and medications. People who are prone for allergies are said to be allergic. They are grouped under the title called atopic. Atopy is the genetic predisposition to make the IgE antibodies in response to the allergen exposure. They are always predisposed. So in a normal individual, they produce more of IgG4 when exposed to the allergens. But in the allergic population and the atopic population, they produce more of IgE antibodies. That's all the difference. Etiology is unknown, but there is a strong evidence for a complex of genes with a variable degree of expression encoding a protein factor. Common factors or common disorders are like allergic rhinitis, allergic asthma, atopic dermatitis are the most common manifestation of atopy. Allergic gastroenteropathy is a rare. These manifestations may coexist in the same patient at different times. Atopy can be asymptomatic also. He may be having atopic nature, but may not be having a symptoms. In globe, we have seen that the allergy incidence is growing up. When I started my practice in 1980, it was only hardly about 5 up to 6%. Now it is almost coming near to the 45 to 50%. You have to remember 2 things. When the IgE rises in the system, inflammation do happen in that particular organ. And that organ, we call it as target organ. And any inflammation which happens in the different organs, then the allergy sequence do happen. What are the risk factors? Host factors is hereditary, which I told you, the gender, the race and age. Environmental factors are infectious diseases during early childhood, environmental pollution, allergen level, and dietary changes. So allergy may be Ig-mediated type 1 hypersensitivity or non-Ig mediated. And this Ig mediated may be immediate or delayed. Immediate means it may happen within few seconds to 20 to 25 minutes. Delayed means it happens after the contact of the allergen. The reaction may happen after 6 to 8 hours, but not more than that. So one allergy of a different shock organs, which I told you, the allergy may be happening in the systemic circulation, and the vulnerable organ will be suffering, maybe in the gastrointestinal tract or a lung or in the nose or in the skin. If it happens in the lung and the disease manifested like asthma, main symptoms like wheezing, dyspnea and tachypnea, and typical allergens are yellow allergens, sometimes food allergens. Route of entry may be a inhalation. Even the food allergens may also act as a inhalant and causing this asthma. And coming down to the nose and eyes, causing the rhinitis, conjunctivitis and a hay fever, running nose, redness and itching of the eyes, and typically happens with air allergens. Inhalations, contact with mucous membrane. Coming to the skin, commonly you have seen, heard of it, about eczema. We call it as atopic dermatitis in the particular nature, and urticaria. And main symptoms like pruritic vesicular lesions, pruritic bullous lesions, and typical allergens like aeroallergens, food and drugs also. And route of entry may be injected by the professionals, inhalation, ingestion, or a contact. Intestinal tract, allergic gastroenteropathy, vomiting, diarrhea, various food and drugs. It is in the form of ingestion. Systemic anaphylaxis, we call it as a shock, hypotension, or a wheezing. Insect venom may be because of the insect bite in the form of bee or a wasp, or drugs, penicillin, foods, peanuts, sting injectants, various injectants. So these are all very common pollens. You can see the pollen from the inflorescence, how the pollens are dropping down in one of the cartoon. And in middle, you can see one of the electronic microscope, how the pollens are visible. And every plant has got its own morphology and architecture. And if you study most of the pollens, you are seeing the wonderful architecture in every pollen. And it is so wonderful. And it has got a distinct nature, shape, and opening, and also has got its own trend of releasing into the environment. And you can see one honeybee with having a lot of pollens. This particular honeybee will visit to these plants, to the particular area and a particular plants, and they collect a lot of pollens on the body, apart from collecting the honey. This is a fungal spores. We have a common fungal spores, and this is one of the alternata. And this is commonly seen in vegetables. And common fungal allergens may be 4 or 5, like Aspergillus fumigatus, Aspergillus stammeri, Cladosporium, and Fusarium, and the Carularia. These are all some of the fungal spores which are very common, which is inducing allergies. This is allergy fumigators. This allergy fumigators, we, especially in the asthmatic patients who are having a continuous, constant, recurrent symptoms over a period of time, then they are likely to get this Aspergillus fumigatus enter in the system and colonizes in the lungs, and we call it as ABPA, aspergillosis. Another important the allergen which is commonly seen in the house dust mite. This house dust mite is a microbe. It works. It lives in every human homes. Whatever it may be, the cleanliness, it may be worst or it may be a clean to clean, still these mites are present. And within the textiles, including clothing, soft toys, upholstery furnitures, and the basic houseless mite food web consisting of the skin scales, microorganisms, bacteria, fungi, and insects. So most of the human beings spend about 6 to 8 hours in the bed, and the scales are shedded on the mattress, and that's why the mites are found mostly in the microenvironment of mattresses and blankets and bedspreads and the carpets. So this is one of the illustrations just to show you how these mites, and if it's the electronic microscope, how the mites, you can see the texture of the textile like a bedsheet. You can see what how these mites are luxuriously moving on the textile. So we have a different important allergen inducing the mites in India, which is very, very common, is Dermatophagitis steronesinus. Another is Dermatophagitis farinae. And we have another is Blomia tropicalis. These are the three one which is inducing allergies commonly. And these mites thrive in the particular environments when the temperature is below 18 to 24 degrees, and the humidity is below above 55. And when the relative humidity is more than 55, you can see in the newspaper report, weather report, if the temperature is between 18 and 24 and the humidity is more than 55, invariably these mites are present in your place. Another interesting factor is, people have already studied about this. This is a fecal matter which is emitted from the mite body, and it is this electronic microscope, and you can see the number of scales which are adhered to the fecal matter, which is very, very rich in protein. And this protein is also eaten by the same human mite body, and this is a very powerful allergen inducing factor. Now coming out of the cockroaches, every house has got a cockroaches. Earlier we used to see a cockroaches going on the floors. Now because of the clean environment, it is seeing in the toilet ducts. And we are living in the vertical story buildings like flats, and in the flats luxuriously it grows, and thousands and thousands of cockroaches are found in the toilet ducts of the flats. These cockroaches need not be visible to everyone, and it is a very lazy creature. It moves very actively only in the particular hours, like early in the morning or late in the evening. When it starts moving, it emits a lot of fine scales from the body, and these scales becomes airborne microscopic structure, and it is available for inhalation. Especially people who are sensitive to this cockroach, they start getting the symptoms when the cockroach starts moving. That is usually in the late in the evenings between 5 and 7 o'clock, and early in the morning again between 5 and 7 o'clock. These particular hours, these cockroach fragments will be, scales are moving, and these allergens inducing the problem, especially in children. Now, the mosquito, we heard about the mosquito which is inducing because of the bites. But later we saw that even the mosquito is having a wings, and which beats in a very high frequency for flying. When it starts beating, the small scales comes out of this wings, and it becomes airborne. It moves from area to area as in the air current, and is available for inhalation. So when you're inhaling the scales of the mosquito, but mosquitoes may not be there. But still, the fragments are there, which is inducing this problem. Now, the another is the culprit is a moth. It may be a cloth moth or a grain moth or any moths which you see in the evening when you put on the lights, and a small butterfly-like black butterfly-like structures which move around the bulbs. It may be within the house, or it may be in the street light, or it may be in the surrounding of 2,000 yards. When it also beating the wings, it emits a lot of fine scales. These scales become airborne and become sensitive. And when you inhale it, you will be getting these symptoms. Dog and cat. These are all the animals which our new culture has been started, and everybody want to have a pet in the house, like birds or a cat or a dog. And these also will be emitting epithelials and the scales from the skin, and it becomes airborne, and that you become sensitized. Especially in a cat, the urine also, the cat urine become a very rich protein, and that also becomes airborne once it is dry. Now coming out to the food allergy. Food allergens may be a variable which may be having a different nature, but top 10 food allergens like milk and milk products, egg, wheat, corn, soya, peanut, and tree nuts. Tree nuts like almond, Brazil nut, and cashew nut, and a walnut. And chocolate, and a fish, and shellfish. Now coming on to the allergy disorders, how to diagnose. Any person who has been diagnosed like your symptoms looks like allergy, the treatment starts from the house. The grandma will be having some solution, or a parents will be having a solution, and they continue. And if the symptoms are becoming severe, then they rush to the doctor, and the doctor confirms it is allergy symptoms. You take this pill, you'll be all right. As long as you are taking the pill, you're all right, you're comfortable. And once you stop it, again the symptom starts. Then you'll scratch, what next? Then immediately somebody says, why can't you go to the allergy specialist? And they come to the allergy specialist, and he has to investigate further. Our main job is to find out what is the culprit which is inducing these problems. It is like Sherlock Holmes, how the detection will be done in the crimes. Similarly, in allergy manifestation, we have to spend a lot on the clinical history and examination, which is very, very crucial before we subject for allergy test. After clinical history and examination, spending a lot of time, then this time what we are devoting is through in the form of questionnaire, because sometimes sitting across, sometimes people may forget and they may not be revealing. So what we give them is a multi-type questionnaire, and they have to fill it up so that it will be under leisurely, they can fill it up and they will be elicited with a clear picture. Then we subject for the different tests like mucus clearance test, nasal smear, nasal flow, and pulmonary function test, which is very much necessary before subjecting for other specific tests. And coming out of the specific test on the allergy, we do a total IgE, which is not relevant right now. Now we call it as specific IgE. Specific IgE is done by in the form of ELISA. You're all very familiar about ELISA. And this ELISA test, we do it, and we run approximately about 180 to 210 allergens, including the food. And whatever shows positive, that we will be reconfirmed with the skin prick test. Skin prick test is to take the allergens and put it on the skin and just prick it for 1 mm to 1.25 mm deep, so that the local reactions happen. It doesn't absorb into the systemic circulation, doesn't induce any anaphylaxis. Skin prick test right now is a gold standard procedure for identifying the allergens, specific allergens. In vivo, which I already told you, that is a skin prick test. And we use the controls, like we use the negative control, that is buffer saline, and a histamine acid phosphate. And we add with the grass whatever the allergens you require. And we will see the reading after 20 minutes after testing. The erythema and a wheal is formed. And depending upon the size of the erythema and wheal, we declare this allergic to what. And similarly in vitro, total IgE and specific IgE, which I have told you. This is one slide which I wanted to inform you and also give you a clear picture. As I told you earlier, atopy is always an atopy from birth to death. And maybe having a symptoms, may not be having a symptoms. Even if symptoms appears, it may appear for a couple of years and again disappears. Again, after some years, it will start. So usually it happens in the first 10 to 20 years. Then you'll be having a holiday without any symptoms. Then you'll be having a symptoms again after 30, 40 years. And again, you'll be having a suffering for 10 to 20 years. Again, it disappears. And usually it happens in one particular organ. It may start by birth with the skin, or it may start with the gastrointestinal symptoms, or it may start with the respiratory symptoms. And usually this, we call it as allergy march. Allergy marches in one lifetime with the different organs. So by the time he understands, you'll be already seeing the different specialties like skin specialist, gastroenterologist, and a respiratory and ENT people, and on pediatrician more than. And all these prescriptions combined together, it is nothing but allergy march. In practice, we always see that gastrointestinal symptoms, their skin will start in the beginning of the life and continues after some time, it regresses. And after a couple of years, then the respiratory symptom starts like runny nose, sneezing. And when it starts, the other two symptoms will come down and gradually increases over a period of time. It persists for one to 2 decades. So allergy is commonly seen with asthma, eczema, urticaria, angioedema, rhinitis, food hypersensitivity, and drug reactions. Now coming on to the one particular organ called the eye. Anything which happens in the eye, we call it as the allergy reaction which happens in the eye, we call it as allergic conjunctivitis, having the watery eyes, itchy, and the redness. When you avert the upper eyelid, you can see the inflammation pattern of cobweb appearance. And you can see the swelling of the eyelids. Then coming on to the next symptom is the sneezing, running nose, and blocking nose. And usually which happens, we call it as terminates in the intranasal cavity. That is, inside the nose, you'll see the hypertrophy of the terminates, the swelling of the terminates. These are all early signs of allergic rhinitis. And you can see clearly how this swollen nasal mucosa. So allergic rhinitis, along with the conjunctivitis, commonly we call it as hay fever, affects approximately 20% of the population. Most starts in the childhood. It may be a seasonal if it is a sensitivity to the pollens, or year-round, perennial we call it as, or a combination. And triggers like asthma, pollen, mounds, dust mites, and animal dander, and non-allergic forms as well also seen. Here, the allergic rhinitis symptoms are nose itchy, sneezy, stuffy nose. Eyes are itching, tear, dark circles under eyes. Ears feel plugged in, and throat is itching, post-nasal drip. You can see some of the children will be having always with a cracky sound in the throat, and that is because of the throat itch, and they get a cough also. The treatment stands for rhinitis is nasal steroid spray. We call it as intranasal corticosteroids. These are all steroids which is a very, very new formulations, new compounds which doesn't absorb into the systemic circulation. Any steroids which enter into the systemic circulation having its own the adverse events if it's not used under the supervision of the medical doctor. And these steroid sprays having a very less toxicity, adverse events are very, very minimal, and non-addicting formation, and well controlled for allergies. The drug may be a fluticasone, budesonide, mometasone. These are the drugs which is commonly used. And antihistamines, which you are all known, like levocetirizine, Avastin, pexafenidine, desloratadine, rupatadine, These are all the third generation of antihistamines, which doesn't enter into the blood-brain barrier, doesn't induce sedation. Sometimes decongestant pseudoephedrine is also used, but nowadays it is not used because it is a banned drug. Eye drops of fluoxetine and Ketlar. Ketlar is which stabilizes the mast cells. And leukotriene blocker, Lucast also is used. Now coming on to the lungs. Lung, you all know, very familiar about the structure of the lung. A lung will be having a tubes, and these tubes where the air is communicated, transported from the environment to the lung to the alveoli. And these tubes are covered with a mucous membrane and small cartilages, a ring type cartilages, and also a smooth muscles to make the air to flow up and down. So in this bronchial asthma, what happens? You can see on the left, there's an opening of the bronchial tube, which is very well functioning. On the right, you can see that bronchial tube, which is contracted, swollen up, and a mucus is formed. And all these things happens in asthmatic condition. And this is only a temporary phase. As long as the allergy is there, that constriction will happen. When the allergy contact is less, or if it's not done, then it becomes a normal. So that's why in asthmatic conditions, once you are having an asthma in the lifetime, you have to suffer from asthma. And sorry. So these asthmatic conditions need not be worried at all. You know that there is one plant called touch-me-not grass. This touch-me-not grass, the moment you touch the grass, it folds. It doesn't fold by other plants. Other plants, anytime you touch, it doesn't fold. But only touch-me-not grass. Similarly, here in the bronchus, who are sensitive to the airborne allergens or hypersensitive type 1 reactions, then these bronchus will contract. Once it contracts, then the entry of the air will be restricted, and you feel that you get that spasm of breathlessness. So once you take some medication, immediately it relieves. And once he gets a relief, then he feels it come out of the a terrible lifetime pain. But it repeats recurrently. But only here you have to protect your lung without getting the attack. That is very, very crucial. Once you protect it, so that your lifetime will be having a comfortable life. So asthma is a leading cause of missed school days due to chronic illness. Same thing happens in the elderly with the earning capacities will be reduced. Economic becomes less because they are not fruitful to function. And severity highly variable. Symptoms include cough, wheezing, chest tightness, and shortness of breath. What are the trigger factors like pollen, mold, animal dander, and dust mites, exercise, irritants, and weather conditions and respiratory viruses? And intermittent do not need daily medication. Persistent do need daily preventive medication. You see, intermittent, for example, exercise-induced asthma. The moment he do the exercises or go for a game, then he will get an asthmatic condition. At that time, he need not worry. He can take some drugs and go for exercise, and he will be comfortable and he can play. Or if he goes to the particular environment, if he gets it, he prepare himself and go there and come back without getting an attack. That is intermittent. And persistent do need a daily preventive medication like mild, moderate, and severe. And severity may change time with the season. Season to season, if the allergy is not well controlled, then the severity goes on, increases from year to year, and he demands more and more drugs for relief. Then he will be hospitalized in the later days to come. So what are the goals with this particular management and when compared to the other disorders? Here, Asthma management is achieved and maintain a control of the symptoms are very, very top priority. Maintain the normal activity levels, including exercise. Maintain pulmonary function as close to normal levels as possible and prevent asthma exacerbations. Avoid adverse effects from asthma medications and prevent asthma mortality. What are the relief medications? You see, when there is a immediate acute attacks, that means you are right 1 minute earlier you are totally normal, now immediately you got an attack and you should need some immediate relief medication, that is rapid acting inhaled beta 2 agonist like salbutamol. Systemic glucocorticoids for a long-term management. Long-acting inhaled beta 2 agonist also can be given. Anticholinergics in the long term in the COPDs, and also if they are not responding comfortably with an beta 2 agonist, then anticholinergics has to be supplemented. Theophylline is a drug which has to be given orally when all other inhalers fails, and short-acting oral beta 2 agonist has to be given as SOS drug for immediate relief. Now, the children should have a quick relief or rescue medication at school, such as salbutamol, theophylline, terbutaline, I explained. Rare use of nebulizers. Nebulizers, they feel it, they are comfortable by using a nebulizer. Nebulizers, nowadays we feel it that nebulizer should not be given to the patient for his management. The reason behind is, we have got plenty of inhalers are available and the spacers are available. You fix the inhaler to the spacer and take it through the spacer, and that will be more effective rather than nebulization. Then the nebulization, if it's not properly used, not properly washed, then the contamination do enter and the infections do happen. Number two, these nebulizer solutions may not be generated properly in the nebulizer, and that's also inducing a problem. So nebulizers are not commonly advisable, and since there's a trade industry which is promoting a nebulizer for a total relief, it is totally wrong. So if they are not properly functioning and they are not properly understanding, this nebulizer should not be used. Only the inhalers with a spacer is a better approach rather than nebulizer, and may become capable of carrying and self-treating at middle school level. So once you make the baby or a child to comfortably do their activities, they will be like almost normal stream of life. Another one called Urticaria, which is inducing on the skin. You're all right and suddenly you'll get a itching and suddenly you'll get a swelling on the one part of the body, and gradually it spreads to all over the body. Then you will become more anxious how this has happened, and you also feel that you are almost nearing to the death. It is not so. Urticaria is just very comfortably, it happens in the skin, and itching will be there. Only itching will be the hallmark, and this can be controlled by using antihistamines. And this is seen the rashes on the posterior part of the body. And you can see that swelling happens on the eyelid. It may happen on the lips, upper lip or lower lip, or suddenly your earlobes swollen up, or your nose is swollen up, or you may be having a bump on your forehead, or you may having a bump on any particular organ like stomach or in the buttocks or different places. This happen if the swelling happens in the tongue. This is angioneurotic edema. This is a life-threatening issue. If any rashes happens anywhere in the part of the body, no problem. The moment it happens, the swelling in the tongue, and the swelling happens in the tongue, it blocks the glottic area, and it is in the throat, it swells up, and the air will be choked. So it is almost near to the death. You should rush into the hospital for anti-allergy drug to be injected. You need not wait for any particular doctor. Any nurse or 24 hours casualty is available anywhere. it may be government hospital or a private hospital or any hospital, you had to rush and see that they'll be always having a emergency drugs like antihistamines, adrenaline. It has to be injected so that immediately it will come down. If it persists for more than stipulated time, then you'll be having the fatality. Now coming to the anaphylaxis, there is one more called anaphylaxis. It's a life-threatening allergy reaction. Many different causes: itching, hives, flushing, difficulty breathing, vomiting, diarrhea, dizziness, and shock. Individuals with asthma at a greater risk of severe reactions. And the known factors like the foods, it may be insect sting like bee bite or a latex contact or unknown. And anaphylaxis action plan has to be initiated. Ephedrine is one of the drug and a cheapest drug and also very effective drug for anaphylaxis. One has to get injected this epinephrine and adrenaline immediately intramuscularly so that the relief will happen within few seconds. No drug like antihistamines and corticosteroids will be having a delayed response, but whereas in adrenaline, which happens within minutes. So treatment of anaphylaxis is epinephrine, oxygen, and intravenous fluids, which has happened subsequently, if necessary. Delayed epinephrine leading a cause of the bad outcome. Some individuals will require more than one dose. Lay the patients down with their feet elevated on their side if nausea and vomiting happens. Call the ambulance and shift the body. So action plan for anaphylaxis if it happens in the college or in the school. And just assess. This is very, very crucial. One has to understand. And you'll be helping your colleague or a friend and to come out of this anaphylaxis. If it's a mild to moderate, swelling of the lips, face and eyes, and having hives on the body, and tingling of the mouth, itchy feet or the palms of the hands, abdominal pain and vomiting, these are all very mild and it can be manageable by oral antihistamines. So watch for the signs of anaphylaxis like difficult or noisy breathing. You'll be breathing very heavily, swelling of the tongue, swelling and tightness of the throat and the throat clearing. He always puts efforts in clearing the throat because this swelling of the tongue and difficulty to talking in a harsh voice. He can't able to give a specific clear message because of the swelling of the tongue. He will be giving a message with a harsh voice. And sometimes you may get a wheeze or persistent cough and persistent dizziness or collapse, very anxious, pale and floppy, young children especially. And this has to be needed, emergency, and it has to be shifted to the hospital nearest by, and it has to be treated. So action is lay a person flat. They should not stand or walk. If breathing is difficult, allow to sit up. If they are in the lying position, if they feel difficulty, then they can sit. Administer adrenaline. Start going to an emergency room by ambulance or a car. Contact parent emergency contact. Further adrenaline dose may be given if no response after 5 minutes. So these are small syringes are available. Ampoules of adrenaline is available. It should be available in all the colleges and schools. Adrenaline with a syringe, like tuberculosis syringe and a syringe, should be available in all the departments of emergency kits. And this, you may give it or you may not give it, at least it should be available so that somebody will be knowing and immediately they start giving the injection. EpiPen junior 0.15 milligram or EpiPen major, that is adults, 0.3 milligram is available in the market, but not in Indian market. It is an outside market, but very, very expensive. Adrenaline will be costing about 2 to 15 rupees in India. And this EpiPen will be costing about 2,000 to 10,000 rupees per single dose. And it can be used and it has to be discarded. So it is not advisable. Better to keep this adrenaline with a syringe. This is how EpiPen is used, and the guidance is given and the training is given to the patient how, if it gets any reactions, how it can be given over the hands. Reaction in the eyes, like itching, redness, tearing, swelling around the eyes, which may be common in increasing in frequency, may affect the skin, GI tract, upper and lower respiratory tract, heart, blood vessels, and the symptoms mild and localized anaphylaxis. Common foods include peanuts, tree nuts, fish, shellfish, egg, wheat, milk, soya, which is all listed as per the Western literature. But in India, we are seeing only about 3% of the population is suffering from allergies. Peanuts are very rare, which is hardly we can see about 0.2 to 0.5%. And you need not be worried about the present condition, but because of the lifestyle changing and the foods which are changing, likely we are also sensitizing to foods in this listed above. And this is again, you had to rush to the hospital and treat. Coming out of the bee sting allergy, most bee stings results in a small local reactions which hurt, burn, itch and swell. Apply the ice, antihistamine if available, something for pain if needed. So these are the things first aid you have to do it. And the local area where there's a sting is there, just by cautiously just remove the sting from the local bite. And large local reaction, same approach, but may need a physician visit to a short course of oral steroids. Stings on the head or neck, greater sublingual will be there. Systemic reactions cause symptoms distant from the sting sites. Reactions limited to the skin in children usually have a benign course, and skin plus any other symptoms means anaphylaxis. If in doubt, use epinephrine. Even if the reactions happening and cause is not known, you need not wait for the cause to know, just to see that the reactions comes down by using the epinephrine. We had a couple of years back, one patient had a bee bite in allergy because the family has come to the flower show in Lalbagh and a heavy rush was there. One baby was bitten by the bee, and instead of taking that child into the nearest to the hospital, they spent a lot of time in reviving by putting the water and shouting on the baby. And by the time they realized that symptoms are increasing and they could not take it to the hospital and the baby died. So when you can't recognize the sequence, and if you're not approaching properly, then these things do happen. Lalbagh being the center of the city, and just walk out of the Lalbagh, you'll get a number of clinics and hospitals, and they would have survived with one injection, and that was not able to give it to that baby. Another group called atopic dermatitis. Atopic dermatitis do happen on the face with the eczematous lesions on both the cheeks, on the nape of the neck, or elbow joints, or a knee joint, or a popliteal fossa. And this is usually seen commonly in the birth. By birth itself, you'll be having eczematous lesion. You need not be scared about these lesions on the skin, which gradually fades off over the period of time. And this is the close-up how the eczematous lesions you can see on the cheeks, and you can see in the lower limb, and you can see on the back side of the leg, and also you can see in the forearm where the bracelet is kept, and it is also on the back of the shoulders. Now, we learned about the clinical manifestation of allergies. Now we had to know what these allergens are. Allergens are molecules foreign to the human body, capable of inducing an immune response characterized by specific IgE, are always proteins, have no functional or structural aspects in common. All antigens are potential allergens. These are all glycoproteins. Proteins associated with the sugar molecule, we call it as glycoproteins. And these molecules having a potential allergens, which is ranging between 5 kD to the 100 kD. So every allergen has got its own range. We call it as major allergen, and these major allergens can be assessed only by Western blot. By Western blot, we know what is a particular molecular weight which is causing that allergy by incubating with the patient serum, and that's how we call it as major allergen. And all these allergens which is having a major allergen which induce allergy reactions. Sources of airborne exposure, which I already told you, from the plants is a pollen, mites is a fecal particles, mounds, spores and a mycelium, and stinging insects like venom, animal ganders. And this is one of the STS paging done with one of the house dust mite extract, this allergen. And when you do this particular mass spectrophotometer, mass spectrometry, and this particular range of pollens we can see in the different KDs and particular molecule, this can be done with a Western blot, and so that you can see what is that particular molecule which is responsible for inducing allergies. That's how this major allergen is detected. Now, coming on to the diagnostic procedures and what are the tests we do. As I told you earlier, the IgE binds on the mast cells, and mast cells, you see, IgE is released from the plasma cells, from the B cells to plasma cells, then IgE is released into the systemic circulation. And this IgE is assayed by the directly called total IgE and ELISA. And now in the recent days, we call it as a specific IgE to particular specific allergen. We call it as specific IgE test. Now, in a different level, like a mast cell basophil binding, at that time, you can see a cellular ex vivo test is done, like histamine release test, leukotriene production, basophil activation test. These are the tests which is very crucial in a research field rather than in the medical field. And coming on to the particular tissues which is affected, like skin, nose, and bronchi, allergens directly challenging into this particular tissues, they react, and this is called a challenge test. And so directly or indirectly, we have to all these combination of these tests can be done so that you'll be getting a total rewarded identification. Commonly, we do a skin prick test after detailed history, which I told you, and a clinical examination. Then the subject for skin testing is a good standard. And these allergens are put in a different on the forearm and the arm at an interval of 2 centimeters apart. And we after the reading, we take the reading after 20 minutes. We take the size of the peel and erythema. Sometimes we get a juicy particles or juicy fruits like apple or pineapple or banana or any of those things. We will take those fruits and we'll pierce the fruits with a lancet, and that lancet will be inserted in the skin. And if any reactions do happen, if it's allergic to that particular fruit, that will be shown in the skin. This is called prick-to-prick test. So these are the reactions. You can see the peel and erythema. Another test, we call it as PAS test. It is a delayed hypersensitivity, which I showed you. That is for stick to particular dye in the hair, which is coming in contact with the skin, and you will get a contact dermatitis because of the hair dye, or a bindu dermatitis because of the stickers which you are putting on the forearm, on the forehead. And sometimes you may be having a metal like necklaces and other things which just comes in contact like rings. You put with a ring on your finger, and that may be a metal comes in contact and causing these reactions. That can be assessed by using this patch test. And once you put a patch, you will take the reading after 48 to 72 hours, and you can see different degrees of reactions. Then we can avoid that particular contact so that the contact dermatitis will heal by itself. Now, coming out of the scheme of allergy treatment, I think I am already covering about 1 hour, 10 minutes. I think if the organizers permit me to continue, I will go ahead with the treatment. Is it okay, Dr. Ramesh? Dr. Ramesh?
Sir, how many slides we have?
Another few 10 minutes, 10 to 15 minutes. 10 minutes I'll cover.
Okay, run through later on because a lot of questions we are expecting. So
Okay.
we can have an interaction.
We'll try to cover as much as possible at the earliest.
Yeah.
Scheme of allergy treatment mainly depends upon the avoidance of allergens. Once you know what is the type of allergy so that you can avoid, then the medications which I have already discussed, the particular organ, particular drugs has to be given so that they will be symptoms are under control. Only recurrent symptoms can be controlled only by using the allergy shots, which we call it as immunotherapy. And also to do all these three factors, you need education and you should know what's the nature of allergen and how it comes in contact, how to come out of these symptoms. So this prevention, which I have already told you, and the immunotherapy, it is nothing but the administration of series of injections of dilute allergens and must be repeated every 2 to 3 years. So what is the definition, which is defined by WHO position paper 1998? Allergen immunotherapy is the administration of gradually increasing quantities of allergen vaccine to an allergic subject, reaching a dose which is effective in ameliorating the symptoms associated with the subsequent exposure to the causative allergen. So it has been demonstrated that it decreases the allergen-induced inflammation in allergic rhinitis and allergic asthma. The main mechanism is, you see the antigen-presenting cells in the center, and by using natural exposure like a low dose of antigens by nature, and they produce more of stimulating the Th2 cells, either by interleukin, by stimulating, secreting the B cell, which secrete IgE, or Th2 stimulation with the IL-5, which increases eosinophil and induces allergy. That is what we have discussed earlier. Now, with the immunotherapy, high dose of antigen, which is either in the form of injected or in the form of different forms, which I'll be discussing shortly, it stimulates more of, to secrete more of Th1 and T regulatory cells. And Th1 will stimulate to secrete more of interferon gamma, and IgG is produced. And these T regulatory cells, IL-10, IgG4 is secreted, and tumor growth factor beta, IgA is secreted. That's why they are immunized. And here what happens, over a period of time, the response happens immediately within hours and a week, over a period of 1.5 years and 3 years. You see there is a decrease in the particularly mast cells and the basophils are decreased, and gradually increasing the IgG4, and early increase and late decrease in specific IgE. So this, by doing these mechanisms, we found that allergy immunotherapy has got a better role in management of allergy disorders. So what are the other role, regulatory role? One is whether it's so allergens is injected, and this suppression of the mast cells and basophils and eosinophils, and suppression of the effector T regulatory cells, and there is a suppression of a tissue inflammation, and a suppression of mucus production, and a suppression of inflammation of dendritic cells, and a suppression of IgE and induction of IgG4. So efficacy is the only treatment that can modify the immune response to allergens and alter the course of allergy disease. In a recent time, we have heard about the biologicals, the monoclonal antibodies, which is also coming into the therapeutic force, but it doesn't alter. It will only suppress the severity of the reactions, and they bring it back to the normal, and it is acting as a passive immunotherapy, but not as an active immunotherapy. In some of the guidelines, the indication of allergen immunotherapy for asthma and rhinitis has been separated. This is not true. The reason is the rhinitis which has happened in the nose and the asthma which has happened in the lung, and the nose and the lung are both are connected together. It becomes a one organ. So it is a united airway disease, we call it. Now, what are those allergen extract? Any allergens which has happened, any allergy to the particular group like pollens, dust mite, or insects, and they extracts. We take the glycoproteins from these particular allergens, and we go for diagnosis or a treatment is prepared by incubating the allergen material in a physiological buffer, like a phosphate buffer saline, followed by a lipid extraction. Allergen content was commonly expressed in crude terms such as protein nitrogen units or weight by volume, but it may now be expressed as micrograms or a specific allergen per ml. So total protein content is expressed now. And several commercial extracts used in the skin testing are standardized regarding allergen protein concentration, composition, and the lack of irritating contaminants. Now the allergen extract is coming in the form of aqueous vaccines, depot and modified vaccines, and a mixture of allergen vaccines. So the quality of the allergen vaccine is critical for both diagnosis and treatment because these are all biological materials, not a synthetic material, which is always uniform. Here is variable. Where possible, standardized vaccines of known potency and shelf life should be used. Standardization allows definition of the potency of allergen extracts and warrants that the batches of vaccine production from different lots of raw materials are consistent, have comparable activities. Standardization can be made biologically. The potency of the vaccine is compared to the cutaneous response obtained in reference population. Immunologically, the potency of the vaccine is based on RAS inhibition experiments using a standard pool. Now, the standardized allergens are expressed in the different units and in a different countries, in a different environments. And protein nitrogen units, PNU, is a worldwide. Allergen units is used only in US FDA. Biologically equivalent allergy unit, that is called PAU. Biological units in Europe and international unit, WHO, and index of reactivity in Europe, and specific treatment units in Germany, and activity units by RAST. So there is no consensus on the particular one. These units are expressed on their own lab standards. The major allergen content in the microgram per ml is provided for most of the products. Standardized allergen extract should be preferred for allergy diagnosis therapy, which is only a limited allergens which is available in the globe, not only in India, even outside. Only few allergens are commonly like house dust mite, and a few pollens are available, but may not be for. So it is a personalized medicine. After the test is done, the prescription will be written by the allergy specialist, and according to the need of the patient. Suppose a patient is showing by allergens which is showing a very high positivity to pollen, then he selects among the 5 pollens what are the pollens which is needed for therapy, and he combines that particular 1 or 2 pollens depending upon the history, depending upon the exposure to the patient, and depending upon the availability in that environment. And then the formulation is done in the pharmacy, and it is a personalized medicine. It is not like any other drug which is. So what are these effects on immunotherapy? Symptom improvement and the reduction of the need for symptom drugs in allergic rhinitis and asthma. Long-lasting effect on discontinuation. Prevention of the onset of new skin sensation and prevention onset of asthma from allergic rhinitis. Safety. Millions of subcutaneous immunotherapy injections are administered annually. The risk of a fatal or near fatal systemic reactions is extremely small but not completely absent. Physicians prescribing or administering subcutaneous immunotherapy should be aware of these risks and institute appropriate procedures to minimize them. We have a non-injectable route also, like oral, bronchial, nasal, and sublingual. Among all, only the sublingual is approved by global authorities like US FDA and European Medical Agency. And among this sublingual, we have got a drop soluble tablets and a soluble film, and kept under the tongue for 2 to 3 minutes, maintained. There is no build-up phase. Usually in the skin, we give a different dilutions, and we start with a particular dilution, then go to the maintenance dose. That happens in the injectables. But whereas in sublingual, we can go directly to the sublingual area, the high concentrations, it doesn't react, and it is a daily dose. So this is sublingual route. Saliva is an aqueous fluid, act as a protective fluid for the mucous membrane. Maintain the pH of 5.5 to 7. Fast dissolving. Sublingual administration with dissolution time 1 to 2 minutes. Rapid absorption and faster action. Greater absorption with reduced side effects. Avoid GI exposure. Directly it goes to the systemic circulation. Therefore, GI is avoided, and less stomach upset and improved safety. So efficacy is again very high. And with this, I am concluding my session. And if you have any questions, please let me know. Hand over to Dr. Ramesh. Dr. Ramesh.
Thank you, sir. I would request Girish Chandra to take the proceedings
Yes, sir.
and
Thank you, sir.
monitor the discussion.
Yes, sir.
Yes, sir. Thank you, sir. So we have a few questions which have been sent in the chat boxes. From the YouTube streaming, the question is from Mr. Kumar Swami. Many people are coming up with allergies to the sanitizer being used nowadays. Will it lead to allergies if you use sanitizers used in public spots, public places?
See, the sanitizers having alcohol more than 80%, and this is a volatile, and it may not be having an impact on allergy reactions. And because of alcohol being a sensitizer, so you may have a contact irritant. It acts as an irritant. So frequently using with a sanitizer may not be advisable. Instead, they can go with a soap, repeated soap washing.
Sir, there is another question from Mr. Mahendra Jena. Sometimes while taking egg and prone allergy grow, is it totally curable? Egg allergy, is it curable?
You see, allergy, the word using a curable in allergy is not the main target. The allergy is not happening, when there is no allergy, he is not having any disease. Only when the reaction happens, only that sequence will be having a symptoms will be seen. So allergy is not a curable disease. It is only we are making the body not to react repeatedly and developing a tolerance to that environment so that reactions will not happen repeatedly. So we enhance the tolerance rather than curing the disease. So we are not using the word cure.
Something should be managed.
Yes, it is a manageable, and also say that repeatedly the body should not be reacting so that the tolerance develops by itself. And once the tolerance happens, so they will lead into the normal life.
Okay.
So we have another question from YouTube chat box from Mr. Ramakrishnan Sharma. Sir, is there any treatment for rashes, boils due to taking dalchini or people or long black pepper, etc.? I'm really sorry, I'll rephrase the question. It's a little confusing.
Okay, I understand. Probably if I take that particular food, which may have a rash and persistent symptoms will be there. So only question is identify that particular food and you can stop taking that particular food so that the recurrence of rash will not be there. So at present condition, we had to stop the food, sensitive food and consumption.
His question also continues to ask if dalchini, people, long pepper or black pepper can be used for COVID-19. I don't know if it is relevant for the talk.
Yeah, we're all talking about the immunomodulators. So these are all the ones which comes into the forefront for immunomodulation. And these are all comes under the Ayurvedic people. So Ayurvedic people would be able to give a correct picture. So this dalchini and pepper may be acting as an astringent, and my knowledge of limitations to these two materials is very, very less. But we use the pepper for the absorption of allergens very faster. So it motivates the absorption from the oral to the systemic circulation.
Okay. Sir, we're done with the YouTube questions. We have questions on the Google Meet platform. Dr. Sharan Goda Patil has asked, to control allergens, nasal passage onion juice is used by Ayurvedic practitioners. Does it really work? Is there any negative impact on the lungs and related organ systems?
We heard about the nasal delivery of the vaccines. We heard about the newer concept in delivering of the drugs within nasal passages, like psychiatric drugs and also neurotropic drugs, which has been advised. And in the Ayurvedic preparations, we don't know what sort of purity is available and what of the contaminations will be available. If the contaminations, if it goes beyond the nose passage, they'll be possible of getting affected in the lung. So one should be very careful in using these drugs in nose.
So the next question is, why class switching will not happen for allergens?
Can you repeat?
Why class switching will not happen for allergens?
Class switching means what?
This is from
IgG.
Raghavendra, you can sign in and talk. This question is from one of the faculties, Dr. Raghavendra Hegdekate.
Hello.
Yes, sir.
The question is, class switching means instead of from Ig, if I am exposed to same allergen second time,
Yes.
why it will not switch on to IgG or any other antibodies instead of IgE? For any other antigen, it's like class switching will happen. But why not for allergen?
You're talking about the switching from TH2 to TH1, right?
Not T cells, with regard to antibodies.
Antibody switching.
Antibody switching from IgE to IgG, right?
Any other antibodies.
Yeah. You see, the immune system is so sensitive and yet to understand so many factors. But in the present knowledge, what we have, so we have got epitopes, and these epitopes are responsible for inducing these allergies. And these allergens are produced only that particular molecule of IgE. And now we are thinking of producing more of IgG. So that is a switching from IgE to IgE we know. And beyond that, we can't able to generalize the scheme. If Dr. Ramesh knows something about it, you can some knowledge on this.
Let me add a little bit of this class switching problem. Usually a class switching occurs from IgM to IgG. That is during the course of primary activation and secondary activation of the immune system. But, during which what happens when the clones of T cells and also B cells develop. B cells, as you know, they will undergo a process of somatic recombination or somatic gene sequence recombination as far as the Ig gene is concerned. Okay, so the class switching is decided early. Initially, because of the presence of IgM and IgG sequences that are proximal to each other, IgM is produced in the primary response of the immune system, and afterwards there will be a class switch to IgG as such. So rest of the other immunoglobulin molecules are a consequence of joining of different gene sequences during the development of the B cells from the germline. Okay, so there is no coming back of IgE producing B lymphocytes or its progeny to IgG molecules. One more thing you have to bear in mind that these are terminally differentiated cells. The B lymphocytes are terminally differentiated cells, and they will not come back to its original, primordial status. So the B lymphocytes after activation differentiates into plasma cells, and the plasma cells after producing the required antibodies, it will die. Okay, those antibodies are released into circulation. One more thing you have to bear in mind is that whenever there is activation of a clone of B lymphocytes, it also simultaneously generates memory B lymphocytes. So although the differentiated plasma cells die, there will be a population of memory B lymphocytes, and at the same time, those T lymphocyte clones that activate the specific clone of B lymphocytes, they also produce memory cells every time. So it's a perpetual presence of a specific population which is destined to produce IgE molecules, not IgG. Initially, you have heard from Dr. Nagendra that IgE is produced by the B lymphocyte whenever there is a kind of milieu, interleukin milieu around the differentiating B lymphocyte. The interleukins are cytokines that are responsible for a B cell or TH1 and TH2. Instead of activating TH1, TH2 is activated, and that TH2 activation is a consequence of prevalence of a microenvironment of specific cytokine molecules. So that's the reaction that goes on. So TH2, when it is activated, the TH2 not only produces effector cells of TH2, but it also produces memory TH2 cells that will be there in our secondary lymphoid organs.
Thank you, sir. Thank you, sir.
Thank you, sir. The next question is from Sanju Barik. Sir, you said one of the factors of allergy response is gender. How does it work? Gender is one of the factors.
Gender. Yeah.
So are there any genes in the sex chromosomes involved for defining the gender-based allergy?
Probably yes, I don't know. We have not gone to that level of understanding. Again, I had to request Dr. Ramesh to give some exposure if he has already known about it.
Well, possibly it so happens that the hormonal milieu inside the body between men and women are different.
Yes.
Some hormones.
There is a paper which is already said about the estrogen becoming more sensitive, and that is one of the responsible for this inducing, probably, but not in the level of genetics. I don't know. Genetics,
at least genetic predispositions are there for some allergies, like the butterfly rash that you get typically. What is that? SCID, SCID.
Yes.
So that is more prevalent in women, and also among women. Only certain races are genetically they are predisposed for developing that type 1 hypersensitive reactions.
You're telling about the SLE, systemic lupus.
Exactly, systemic lupus erythematosus. The typical butterfly rash that appears are more prevalent in women than men. So possibly, the hormonal milieu inside the body would determine whether they will be predisposed to a situation or not.
Yes, sir. Next.
Thank you, sir. I'll move on to the next question from Rojali Said. This is from YouTube chat box. Does someone having allergic bronchitis catch COVID-19 more easily? What should be the precautions if that is the scenario?
With the present scenario which we have seen, we thought earlier, early stages we saw that COVID COVID is likely to get affected to the patients who are suffering from allergy respiratory disorders. We thought so in the beginning, but now we found, and most of the allergy patients who are not suffering from the COVID because they have got a more tolerance, and also the inhalers which they use, they containing corticosteroids which has been on the surface of the epithelial, which may be acting as a barrier to the COVID virus to penetrate into the system. So these are the two factors which has been expressed, and that's why all our allergy patients are really safe with the COVID rather than getting vulnerable for reactions.
Okay, so selectively it is beneficial.
Yes, it is a beneficial. It is a beneficial, and they are not vulnerable for infection to the COVID.
Okay.
Yeah. We have a lot of personal questions, like if we visit some places, we get allergy or rashes. I'm just avoiding such questions. I'll take up one question from Ms. Tabassum Sheikh. I'm not allergic to any food, but I get rashes during winter season only. What could be the reason?
The winter season, definitely the environment changes, and probably you may be exposed to the pollens, or it may be exposed to the mites, which may be responsible. And these are all airborne allergens, which is inducing the particular environment and a particular subject and inducing these rashes. So probably one has to assess what is the nature of the reactions which is happening and how to come out of this problem.
So the next question is, I think it's interesting. This is from Dr. Sharan Goda Patil. Avoiding allergens is good, or to adjust with them to boost up the immune system? What is good? This is in particular to make the BBMP workers strong to fight with the current COVID situation. Is it okay to avoid allergens, or is it good to take up the allergen challenge and boost up our immune system?
With the present scenario or a present condition, over a period of time, we are exposed to this particular subjects who are suffering from allergy disorders. If the symptoms in the early stage, and if you could able to avoid and prevent it, and the symptoms are not recurring, and occasionally, if suppose if you're getting the symptoms of frequently, like once in 2 days, 3 days, and later, if you give a measure of prevention, and the symptoms may happen on only once in a time, like once in a month, or once in 2 months, or once in 3 months, then prevention is really works. And once you make the preventive, then the body will learning to produce more of IgG rather than producing IgE. Then the tolerance definitely enhances. So there is a natural enhancing of the tolerance. But in most of the cases, it is very difficult to do it. It's not possible to do it. So naturally, they had to be identified and protect and prevent and use the medications as and when required. If the demand of the medication goes up higher and higher, then allergen immunotherapy is only the final answer.
Okay. We have a question, probably in a way the person is asking for a live consultation. A few hours ago, I just was attacked by bee. Painful and affected area of my neck is swelling after he removed the sting. So what could be the remedy, or should he run to the doctor?
If the already it is more than 2 hours or 3 hours, then local application will be done, and you can apply some ice cubes on the local area so that it will not spread into the systemic circulation. And secondly, you can take some antihistamines, and local applications you can have some antihistamine ointments that will take care of it. If the swelling goes on increases, then immediately he has to rush to the hospital and take some antihistamine injections. If the oral is enough, then there's no need to go for injection.
Yeah. Mentioning the antihistamines, we have a question from Mr. Lingaraju. Is serotonin also an anti-allergic substance like antihistamines?
No. Serotonin is a different entity which may not acting as an anti-allergy drug. So it is not it can be given for immunomodulation purpose, but not for allergic effect. For immediate resolving the issues will not be helpful.
Thank you, sir. We have one final question from our colleague, Dr. Raghavendra Hegdekate. Dr. Raghavendra, please ask.
Sir, question is, during the treatment, whether hyposensitization or desensitization, which will be preferred for treatment purpose?
No. Treatment purpose, we are doing the desensitization, the hyposensitization, not hyper. Hyper is reactive. Hypo is reactive. Hypo. So hypo and desensitization both are same. So now we had a different words which were used over a period of time. Now we are using as allergen specific immunotherapy. It is more or less a desensitization. You are already sensitized to particular allergen. We are making that body not to react to that particular allergen on exposure. That is called desensitization. I hope I gave you the answer.
Yes, sir. Thank you, sir. But another thing, what I know, sir, is during this process, some people, they will tell that it will be switching from IgE to IgG So that is the reason that hypersensitivity will going to decrease. So how much it is true, I don't know.
You see, the main mechanism of this action of immunization is in allergy people, they always having IgE is produced. And instead of producing the IgE, we are teaching the immune system to produce more of IgG. And this IgE is a blocking antibodies. And this is once enhances, naturally IgE will come down and desensitization happens.
Thank you, sir. Thank you.
Welcome.
Thank you, sir. We are done with the questions. We have a lot of personal questions like, running nose and all allergy issues. So we'll not be taking any more questions. I request Professor Ramesh sir to address us for conclusive remarks. And it will be followed by vote of thanks.
Thank you so much. I'm sure every participant has taken the best advantage of the expert opinions with regard to allergy and its therapy as such. Dr. Nagendra Prasad, as I told you in the beginning, he has been into the allergy study and diagnosis and therapy for the last 40 years, and it's really good for him to be with us and spare some time to impart his knowledge and also enlighten the youngsters over here. And for the youngsters, the message is that there is a lot to be done. There is much more research to be done in the field of allergy or immunotherapy, or it may be hypersensitive reactions as such. Because many things we are yet to understand, and the treatment strategies have been evolving from beginning to until now. I remember that in the beginning there were no prophylactic agents to prevent the triggering of the whatever anaphylaxis or asthmatic attack. Now a variety of prophylactic agents are available, by the virtue of which many patients have a sigh of relief. So like that, this entire process of persuasion of diagnosis and development of strategies or medications or whatever is a continuous process, and there is ample scope for everybody to get involved in this kind of research. More than that, we know now that IgE is the culprit in the whole situation, because IgE, once it is produced, it will go and bind to the receptors on the mast cells, so that right now the situation is that we treat IgE and mast cells as villains, because they are not helpful for our body, and neither they induce a lot of uncomfortable situations. But recent research, I'm talking about at least 3 years ago, there were a lot of publications with regard to the role of mast cells in our immune system. And there has been many papers that actually have projected that mast cells are very essential for some other function as such, without which we cannot live properly. Now that is the reason, probably, I believe that whether it is IgE or mast cells, right now they cause a kind of reaction and they cause a kind of disease as such. But natural selection has retained those molecules and those cells, and probably it is for us to understand why those molecules are retained in our system, why those cells are still retained in our system. Otherwise, if it were to be evolutionarily not required, natural selection would have eliminated those cells and molecules. So there is something in store for everyone, every youngster over here, to think about this and then get into research to find out the answers. More than that, of recent, probably 5 to 8 years ago, we know a lot of information with regard to the non-coding RNA molecules or microRNA molecules or long non-coding RNA molecules, and they actually regulate the process of hematopoiesis. Until then, we knew only about cytokines that are produced by stem cells and also different kinds of hematopoietic cells. They creation or production of different kinds of blood cells. Now, beyond that, now we know there is enough evidence and also information to appreciate the role of non-coding RNA molecules, which actually regulate which kind of cell has to be differentiated, which kind of cell has to be produced after in our bone marrow to take care of many things that has to happen in our body. So likewise, research is never ending, and new informations are being made available. And the take-home message is that as the technology develops, we'll be able to find more and more answers, and that may be helpful for better living. So I would like to once again say that Dr. Nagendra Prasad has been kind enough to spare nearly more than 2 hours, and it's time pressing for any physician or a doctor, because patients need their service more than academicians. But thank you for sparing your time. And I would like to inform everyone that Dr. Nagendra Prasad is MBBS from Mysore Medical College. So he belongs to Mysore for all academic inputs. And later on, he shifted to Bangalore for his service, rendering his service to the society, and also to undertake research in this very throbbing field, very contemporary field. And he has been successful in establishing his own research center. Finally, I would like to tell you that please, for the youngsters, the message is for the youngsters once again. Food allergy is one kind of situation that everyone has to know. At least the life science students have to know, and spread the message across with your known people, known contacts, that food allergy should not be ignored. The best treatment is to avoid that food. Okay, especially when it comes to the seafood. Many people are allergic to seafood, especially when it comes to oyster. I know particularly one evidence or one instance where a young researcher, without realizing the food allergy aspects, of course he was a researcher in biological science, but you see the fate pushed him to death because he happened to eat oyster meat unknowingly, and he choked into death. Very sorry to say that. It can lead to serious consequences. So that's why when you go to a new place, especially when you go abroad, then restaurants have a note to say that you are allergic to which kind of food, because for the first time you are going away from India into Western countries or Western restaurants. You will not know the components of the food. Then you are at liberty to ask the composition of the food, and if you know that you are allergic to a particular food, you better don't take that food. This is my personal message to all youngsters who are trying to go abroad for various academic programs. Well, on a light note, delayed hypersensitive reactions can trigger as a consequence of coming in contact with metallic ions and also certain kinds of plants. It is just on a lighter note, metallic ions such as gold it may trigger the delayed hypersensitive reactions. So if it happens for a woman, probably she has to switch over to platinum instead of gold. So with these few comments, I'm closing my remarks. And once again, profusely thank Dr. Nagendra Prasad for being with us. And I thank Girish Chandra for rendering the support, and also Tejasvi for managing the whole show behind the screen. Thank you so much, and thank you everyone who have participated in this program. Thank you so much.
Thank you, sir. I'll have a more formal vote of thanks. I'll just present it now. Thank you so much, sir. The speaker of the day, Dr. Nagendra, sir. I place on records the gratitude to Dr. Nagendra, sir, for accepting, first of all, our request and presenting an excellent information which was readily understood by all the participants. I also thank profusely Dr. Ramesh Esa, Chief Scientist of Life Sciences Department, Pooja Bhagwat Memorial Mahajana Education Center, PG Wing of Mahajana College, Mysuru, for personally taking interest in organizing the webinar and also being in constant touch with the speaker. I thank all the participants from across the city and also the nation. And this is currently received by our students of MSc students of biochemistry, biotechnology, botany and microbiology, as well as students and faculty from across the nation. I thank all the participants. I thank the ever-encouraging support from our beloved director, Dr. C.K. Urticaria, for organizing this webinar and all the events from our college. I thank the management profusely for supporting in all the positive events, beneficial events to the students and also the faculty. All the academic events, they will be backbone for us. I thank Dr. Bhagyashree Paul, Shri Basharat Ali, Dr. Shakir Khan, and I also thank Dr. Jayakumari, the principal of Mahajana First Grade College, for encouraging us during the preparations for this webinar. I place on records especially heartfelt thanks to Mr. Tejasvi, Assistant Professor of Computer Science Department, Sheshadripuram Degree College, Mysuru, for his continuous hard work and helping us continuously in making this webinar a success. I thank Dr. Raghvendra Hegdekate, Assistant Professor, Department of Biochemistry, and Mr. Ashok Kumar from Computer Science Department from the PG